Hello everyone, welcome back to Raaonline on another interesting topic on the respiratory system, the interstitial lung diseases. The interstitial lung diseases are a heterogeneous group of disorders which are characterized by inflammation and fibrosis of the interstitium of the lung. And here the pulmonary function studies are indicative of restrictive lung disease. And the previous class we saw about the obstructive lung disease. This is restrictive lung disease in the spirometry analysis. And most of the causes of pulmonary diseases of the lung, of the interstitium of the lung are idiopathic. And it is mostly interstitial component, but rarely it can also have the intra-alveolar component. And there are a spectrum of disorders and we have an overlap of various histological features in the interstitial lung diseases. So thus the interstitial lung diseases are characterized by varying degrees of inflammation, ultimately leading on to fibrosis or scarring of the lung. So this is a normal lung and this is the trachea, this is the normal lung and this is a fibrosed lung as a result of any etiological factor that leads to interstitial damage. So the classification of interstitial lung diseases can be idiopathic, which is the commonest cause. So we classify them as idiopathic interstitial pneumonias, which can be idiopathic pulmonary fibrosis, which is otherwise known as usual interstitial pneumonia, desquamative interstitial pneumonia, acute interstitial pneumonia, non-specific interstitial pneumonia, respiratory bronchiolitis interstitial lung disease, cryptogenic organizing pneumonia or otherwise known as bronchiolitis obliterans lung disease and lymphocytic interstitial pneumonia. These form a major chunk of the interstitial lung disease. Then comes the exposure related, which can be pneumoconiosis where there is exposure of the mineral dusts, hypersensitivity pneumonitis which is the exposure of the organic dusts, and drug induced or radiation induced. And next comes the connective tissue diseases. Here we have the commonest being rheumatoid arthritis, Sjogren's syndrome, scleroderma and the other mixed connective tissue diseases as well as lupus erythematosus. Sarcoidosis is one of the granulomatous diseases of multisystemic involvement which produces significant interstitial lung involvement. And these are the other etiological factors of interstitial lung diseases. So we will see this interstitial lung diseases under these major heading. So all these ultimately lead to pulmonary fibrosis. So idiopathic pulmonary fibrosis, smoking related, autoimmune related, hypersensitivity pneumonitis, drug induced and occupation related. Of all the lung diseases such as COPD, asthma, cystic fibrosis, tumors, etc., this interstitial lung diseases constitute a major percentage of the lung diseases. So this is a normal lung and the normal alveoli. So this is the distal alveoli or the air sacs where gas exchange usually takes place. And this is an inflamed lung interstitium where because of the inflammation as well as scarring, there is difficulty in normal air exchange between the alveoli and the blood vessel. So this is the ultimate thing which is affecting the lung because of the interstitial lung diseases. So clinical features, we have the dyspnea or shortness of breath. The patient may be tachypneic or on auscultation of the lung, we'll have to examine and look for the end inspiratory crackles, which is very specific for interstitial or the restrictive lung disease. Later stages, we can have cyanosis leading on to pulmonary hypertension and carpulmonale. And unlike the chronic obstructive pulmonary diseases which we saw in the previous session, there is no airway obstruction and there is no wheezing. This point is to be noted. So the patient may present with a dry hacking cough which does not produce any expectoration, extreme fatigue or unexplained weight loss with mild chest pain, loss of appetite, labored breathing, shortness of breath, and rarely it can, in severe involvement of the lung, it can cause a hemoptysis. So what will be the functional changes in interstitial pulmonary disease? There is decreased diffusion capacity because of the damage and fibrosis and scarring of the interstitium of the lung, and so there is also decreased lung volume and lung compliance. So the forced vital capacity is decreased, whereas the FEV1 by the FVC ratio is absolutely normal. So this point is to be differentiated between the COPD, the chronic obstructive pulmonary diseases which we saw in the last session, where the FVC is decreased and the FEV1 by FVC ratio is also decreased, especially in emphysema where the value is less than 0.7. Whereas in restrictive lung diseases, classical example of this is the interstitial lung diseases, the pneumoconiosis, the FEV1 by FVC ratio is normal. And radiologically, we can have X-ray finding bilateral involvement of small nodules or irregular lines, the characteristic Kerley B lines, the reticular opacities. Of these, the reticular opacities go well with the diagnosis of ILD in X-ray. And in CT imaging, we can have ground glass shadows because of interstitial fibrosis, and in advanced cases where the interstitial damage is there for years together, we can have a honeycomb appearance of the lung parenchyma. So this is the X-ray picture showing fine reticular opacities.